So as some of you know, we did set up a cardio metabolic clinic a couple of years ago, and we do acknowledge it's a very complex process. We have a lot of resources, nursing, pharmacy, follow-up. We also have a electronic template and checklist. So it's a lot of work to do a lot of things at the same time. It's very similar setup to a heart failure clinic. If those of you practice heart failure, you know what I mean in terms of medication titration and medication management. So it's kind of the same thing. And the renal component has actually become very important. So this is actually a real guy. It's not made up, but I did add some of the background slides to highlight the evidence. So it's a 69-year-old guy, Ali, who has hypertension, hyperlipidemia for 10 years, ex-smoker, had a myocardial infarction 1 year ago and was recently rehospitalized for angina and mild heart failure. Ejection fraction 49%, NT-proBNP 471. So for the outpatient clinic, the cutoff point is 125. For the acute heart failure or the emergency room, the cutoff points are different and age dependent. So his HbA1c is 5.7. LDL is 99 milligrams per deciliter, which is it's about 2.6, with a blood pressure of 138/88. So in addition to prindopril, he's on 80 milligrams of atorvastatin and is taking aspirin. So he doesn't walk, but he has no symptoms. He says he has no symptoms and denies having diabetes. What other information would be helpful to know and determine his current risk? What else could we do to optimize reduction of his risk for future cardiovascular disease events? And I'm saying now cardiovascular disease in a broader perspective. We're no longer just ASCVD focused. So we've seen this slide before, and there are things you can't fix, like his age, his gender, genetics, but we have diabetes and or pre-diabetes, insulin resistance. You have high blood pressure, lipids, obesity is now firmly in the box, smoking, and I'm going to add now in the box below here, CKD and albuminuria, right? This is important in this context in many different ways. And what we're also trying to prevent is, let's just go back a little bit, is a broader perspective here. So it's ASCVD, which includes MI, stroke, and PAD. You also have to look at heart failure, whether it's HFrEF or mild reduced or HFpEF. And also atrial fibrillation is a significant risk in this patient. So where is this patient? He's actually at the late stage of the cardiovascular continuum. So he's already had angina and ischemia, and now he has some element of LV dysfunction and heart failure. So he's actually gone all the way around the circle, right? He's almost at the advanced heart failure stage. If we let him drop, he's going to be looking at something pretty bad. So the additional risk enhancers and biomarkers, we need to know his GFR, right? We need to know his albumin-creatinine ratio, so you have to check it. If you don't check it, you're missing a huge opportunity. What's his triglyceride and non-HDL-C? Abdurrahman was asking that question in the last session. And we have to know the BMI and waist circumference. So these are some very basic lab values, and they change your profile completely, right? So what's a normal GFR? Anyone? Is it 60? Is it 90? What's normal? Normal. 90. All the electronic medical records that I've seen now are saying greater than 60. This is not correct. This is where the threshold changes, but it's clearly not normal if it's between 60 and 90. And remember, the DECLARE outcome study, the average GFR was about 84. Wasn't that bad, and you had a very big outcome in terms of heart and renal events with SGLT2 inhibitor. That's how we realize there's a primary prevention there. Albumin-creatinine ratio. What's a good number for ACR? 0, right? Really, you shouldn't leak any protein. It's a very sensitive test. And as you saw the slide that you showed very nicely, the threshold of risk starts when you go to 10, just 10. 30 is already 3 times higher than 10, and that means the risk of cardiovascular events is doubled. Cardiovascular death and heart failure. This is a very powerful biomarker, and I really don't think we should ignore it. Now, what about the triglycerides? The triglyceride is 200 milligrams per deciliter, and the non-HDL resultant is 130. Now, this patient has had what? 2 cardiovascular events, coronary events, right? So by no means is the LDL or the triglyceride or non-HDL-C acceptable. But he's on 80 milligrams of atorvastatin, doc. Yeah, we have some solutions for that. Now, the BMI and waist circumference have now become very important for us because we have specific interventions that can fit this bill. Last year, if you were giving a talk, you couldn't say that. We didn't have the SELECT study to rest on this information. So lifestyle is important. We've talked about it a lot of times. It's foundation for risk reduction. It's a long-term commitment. It's important to give him a diet. Now, he is on a small dose of metformin, but the small dose of metformin was basically designed not to help him lose weight, but also to manage his pre-diabetes, if you were. And you also have to give him a lot of information on physical activity. So there is a requirement for cardiac rehab. Now, cardiac rehab, we don't have time to talk about this, actually has been shown to decrease cardiovascular events, not only in the year that the patient had cardiac rehab, but for 5 years after that. And you can ask a question, why does that happen? Because it also results in a behavioral change. When people do cardiac rehab as a group, they acquire this healthful activity and they think about it in a different context, right? So that's why there is a long-term benefit of 12 weeks of cardiac rehab. So just think about that. And as Wael said, you know, we make these referrals, a lot of patients don't come. We have to tell them what's the benefit. It's not a gym, it's a program, okay? So we have the dietitian, we have exercise physiologists, there's a lot of benefits, plus it's being monitored. What patients like to know is that somebody's watching them while they're doing the cardiac rehabilitation. So lifestyle management, I am by no means a dietitian, but a DASH diet, moderate intensity activity for 30 to 40 minutes, 3 to 4 days a week, has actually been seen and recommended in the ACC/AHA lifestyle management guideline, which is part of a lot of the guidelines that we're talking about. We don't spend enough time talking about it. And resistance training is very helpful because that's going to resolve some of the insulin resistance. That's just using the rubber bands or just doing a little bit more than he's doing right now, which is absolutely nothing. He just sits in the chair. So, cardiac rehab, very few patients after a cardiac event enroll and successfully complete a cardiac rehab program. There's a huge evidence-based reduction in hospital admission and strong improvement of outcomes. In the United States, it's covered fully by Medicare. It's really mandatory if you ask me about it. So referrals are very important, and also referrals to dietitians are very important. We have to make this step happen. Even if the patient tells you, I know what's going on. No, we don't. I didn't know when I was initially diagnosed with diabetes that drinking orange juice was a problem. I didn't know that. And then a very smart dietitian told me, look, you can eat 1 orange and you'll be full, but you can juice 4 oranges and you're still not going to be full. You're going to drink a whole jar, aren't you? So that was crazy, right? So you don't know these things until somebody tells you, and you don't know what you don't know. So now what about obesity as a target for ASCVD risk? So his A1C is only minimally elevated, and this is a select patient. This patient literally fits a select study profile, right? Minimally elevated HbA1c, and the select study showed significant cardiovascular benefits if the BMI was over 26. Now, this is a little bit different than the STEP-HF and the other obesity studies. This is not a really bad BMI. You think that this patient could sneak through, but there's a lot of benefit here, and these patients without diabetes. So we are unfortunately in this stage of the game, right? He's there in the dark red box. We had a long time, missed years of possible prevention, and he's a late stage of the cardio-kidney metabolic syndrome. Now, what's also hiding in the background, because the focus is cardiac, is that he has a kidney problem, and it's going to get worse. And one of the things I've been learning is that what's bad for the heart is worse for the kidney, and what's good for the kidney is even better for the heart. So we need to take these pieces of information and really hammer them pretty hard. That's where we are now. He could have been here if we treated his smoking, diabetes, hyperlipidemia, and obesity. So this is our UAE cardiometabolic guideline. Many of you have seen it before. We look at patients with dysglycemia in general. So pre-diabetes and diabetes, we sort of look at them in a similar construct. And as was very nicely pointed out, you have to check the urine output to creatinine ratio and GFR. So we made it crystal clear, kidney is right there. We do suggest getting an NT-proBNP annually to find this occult heart failure, the stage B heart failure, which has no or little symptoms because of sedentary patients. An ABI is recommended, an eye exam is standard, and also we're looking for an ECG. And if any of these things fall out, referral is needed to a specialist group. Now, why an ECG? Because sometimes we find atrial fibrillation, and sometimes we find left ventricular hypertrophy, and subtle ECG changes. The difference I think we have is a very sedentary population that doesn't exercise to angina thresholds or heart failure thresholds. So we're trying to unmask these patients, and the screening age is actually 35 in these patients, starting from 35 onwards. So this is the traditional standard exam. So a foot exam is important, retinopathy, forward. Retinopathy, GFR, and UACR. Now, what we've added is a few additional things tailored to the local population. An ABI is there, and we are allowing a coronary calcium score in specific high-risk patients, and I'm going to explain why. It's because we have a large population of very high-risk individuals who are younger than the age of 40. And the average age of myocardial infarction here is 47 years old. So we need to hit this curve earlier, and that's why when we've had people review this from other countries, and they're wondering, why are you doing all that? Because we have this unusual predominance of very early premature coronary artery disease, and it's not just driven by genetics. We feel there's a metabolic component too. So what's the triple target for therapy in obesity with cardiovascular disease in 2024? So now we've seen data from GLP-1, SGLT2, mineralocorticoid antagonist selective. So we want to reduce cardiovascular disease and CKD. This is our dual objective, both together. We want to hit metabolic targets such as BMI, CRP, LDL, blood pressure, A1C, and presumably regression to euglycemia if possible, which we've actually seen in some of the GLP-1 studies, true regression of the metabolic syndrome. So cardio prevention, we're going to take something from diabetes, right? I know this patient doesn't have overt diabetes, but he might as well have in terms of his cardiovascular risk. So Empareg and the other SGLT2 inhibitors show large DM outcome trials, primary and secondary prevention of heart failure. That was the primary driving in the cardiovascular diabetes studies, right? In patients not known to have heart failure, this was driving it significantly. Liraglutide in LEADER showed a 13% reduction of the composite endpoint and reduced cardiovascular death by 22%, but no heart failure hospitalization in LEADER. Okay, this is diabetes. And semaglutide in the pooled analysis of PIONEER and SUSTAIN 6 reduction of MACE in diabetes with ASCVD. So that's diabetes. Okay, so we're going to move forward a little bit and look at SGLT2 inhibitors. So SGLT2 inhibitors have exploded, right? There's probably a lot of interest in using it in other things beyond now metabolic disease. So we have prevention of heart failure in diabetes, prevention of kidney disease in diabetes, treatment of heart failure, both preserved and reduced in diabetes, and with the Soloist, which is an SGLT2, SGLT1 specialized agent for acute heart failure, decompensated or worsening heart failure. Why does it keep jumping? Okay, so there's a lot of items and opportunities for the diabetic patient to get an SGLT2 inhibitor. And now we have non-diabetic patients with CKD and non-diabetic patients with heart failure that are getting both a cardiac and a renal benefit, even if they don't have diabetes. So it's very broad. And it's basically difficult to justify not giving these high-risk patients an SGLT2 inhibitor. Now, what about obesity as a target? So while SGLT2 inhibitors may reduce BMI, they're not indicated for that. The SGLT2 inhibitors are now indicated for heart failure, hospitalization reduction in both heart failure, preserved and reduced, without diabetes. So let's just be clear, we've now taken it over as a cardiovascular drug in its entirety. GLP-1 receptor agonists, liraglutide, semaglutide, dulaglutide, are indicated for cardiovascular disease reduction in patients with both diabetes and ASCVD. So until SELECT, there was nothing that didn't include the word diabetes. It had to be diabetes. So this guy, what does he have? He's obese, he has ASCVD, recent angina, mild heart failure hospitalization. SGLT2 is going to be a must, right? I think there's no question about it. Coming in from the kidney, coming in from the heart failure, he's got to have it, okay? He's also got CKD and microalbuminuria. These are compelling reasons for the SGLT2 inhibitor. I'm going to come back again. So we've now gone through 5 slides. We still haven't addressed the idea of obesity as a target for his residual risk and GLP-1 regardless of the A1C. So SELECT, just to remind you, you had to be a non-diabetic, strictly. So this was not going to include any diabetic patients. And these are patients with prior MI, prior stroke, symptomatic peripheral artery disease, BMI above 27, age above 45. And this was the main exclusion criteria. Type 1 or type 2 diabetes, end of story. Or an A1C above 6.5. So it was very rigid in terms of the exclusion criteria. And you had patients who had an MI, stroke, or PAD, and it's a very well-distributed study. Now, there are also 8% of patients who had more than one cardiovascular event. So these are the extreme high risk or polyvascular patients. So 20% reduction of the cumulative incidence of MACE, all right? And that's a statistically significant number. And in fact, all of the components are important here. This is over 39 months. The other point was these patients were on excellent background therapy. If you look at the treatment algorithm, high-intensity statins, ACE inhibitors, dual antiplatelet therapy, as you would expect in a patient with a prior myocardial infarction. And we're still getting an event rate that's equivalent to what we were getting from the PCSK9 studies. If you think about what we got in the 4-year outcome study or the more recent Odyssey outcome study, which was a recent ACS kind of patient. So this is basically telling us a weight management medication showing reduction of cardiovascular events in people with established ASCVD and overweight or obesity without diabetes. So diabetes is not required for this benefit, right? So the other thing that I found very interesting, and that was something that is now being explored further, is the cumulative incidence of composite heart failure events by about 18%. Now, is it ischemic cardiomyopathy or is it the diabetic inflammatory cardiomyopathy on top of which the patient developed an MI? Is going to be hard to say which exactly the mechanism. Now, let's talk about MACE, because that was a atherosclerosis-driven study, right? The heart failure is just an additional benefit. Now, when you look at the SGLT2 inhibitors in diabetes with ASCVD, it's heterogeneous. Only the EMPEREG outcome study showed this effect of a reduction of cardiovascular disease-related death. The other studies did not. They showed heart failure hospitalization clearly, but not MACE, right? And it may be about the study design or the history of the study, but these patients were 100% in the EMPEREG study, were 100% ASCVD, right? In the CANVAS and DECLARE studies, some of them were primary prevention. They did not have an event. But regardless, the MACE is not a characteristic of the other SGLT2 inhibitors. So I don't expect to give canagliflozin and reduce MACE events, right? But it definitely reduces heart failure, which is valuable just the same. Now, lipid management. So this is a circular discussion. This is not just about obesity, right? So this guy's on atorvastatin 80, but his LDL is 99. Now, the ACE guidelines, remarkably, in 2017, quoted this patient to be extreme high risk. And that's when we got the target of less than 55 or 1.4. It took several years for the European and ACC and finally the ADA to concur with this number. And it's a real number. It comes from the Improve It study, right? So you know that if you added ezetimibe to this patient, his LDL is 99. You add ezetimibe, you're going to get a 15% reduction. So that's not going to get him even to 70, right? Is 70 okay for this patient? 1.8? No. We want to get to 1.4. So even adding ezetimibe is probably not going to do it. And if you look at the ESC guidelines, what is this patient specifically? This is a prior acute coronary syndrome less than 2 years. So the target would be 1.0 if you're going to follow the European guidelines. So there is no way that statin and ezetimibe is going to do the trick in this patient. We have to think about the consequence of leaving the LDL higher. So if you took the ACC 2018 guideline, to achieve LDL less than 70, a PCSK9 would be required as the non-statin agent. With recurrent events, ESC would recommend less than 1.0 for recurrent ASCVD. So this guy is definitely a candidate for a PCSK9. So that's one more thing you're going to have to discuss with him and get the insurance approval for as well. Now, we know that very low LDL has a linear effect of reduction, and this was seen in patients with and without diabetes, in addition to prior ASCVD. And I'm just going to point out to you, there's something called the 4-year study open label extension. So now they have 8-year data from the 4-year study where it showed that the consistent reduction of LDL over 8 years resulted in a 22% reduction of the hardest outcome, which is all-cause mortality. So it's absolutely worth it, but you have to keep doing it year after year. So there's a lot of work to be done on the LDL at this point. Now, what about the blood pressure? So if you recall, his blood pressure was above the target. So his current requirement would be less than 130 over 80. Now, he has ASCVD, and he also has with and without diabetes. The ACE guidelines, again, very forward-thinking, have recommended 130 over 80 a few years ago. So this is a hard number. But what's also going to modify your treatment of the hypertension? He's on perindopril. He has LV dysfunction. He has LV dysfunction. EF is now less than 50%. So is an ACE inhibitor superior to an ARNI in this situation? It is not. Specifically has been studied to be inferior. So we're going to have to think about that. All these are little clues. This is a real patient. We had to work through this over several weeks and months to get him to a optimal treatment benefit. So if you remember, the ACCORD study actually didn't show in diabetes, right, a target of 120/80 compared to 140/90, but there was a stroke reduction benefit, right? The higher risk of stroke would call for a lower blood pressure target. The SPRINT study would argue for a lower target, but the most important point here is he has LV dysfunction with an EF 49%. He's clinically sedentary. He's not telling you he has shortness of breath, but I guarantee you if you make him walk one flight of stairs, he's going to stop, right? And his BNP is high. So he has clinical heart failure and LV dysfunction. So there's a good reason to apply valsartan sacubitril beyond his actual ACE inhibitor. So we're going to come back to the renal risk in ASCVD. That's why it's a cardiorenal metabolic patient. And there's heart failure attached to this as well. So you've seen this slide before. CKD patients are more likely to die of heart disease, almost 5 times higher than to advance to end-stage renal disease. This will happen before they go on dialysis, right? So arresting this cardiorenal progression is extremely important. And the biomarker that you know is reduction of GFR, and even earlier, the reduction of UACR. You can have a normal GFR and an elevated albumin-creatinine ratio. That puts you at that tremendous risk as well. And this is just to show you the impact of microalbuminuria on HFpEF and HFrEF. So the highest risk is a patient with microalbuminuria and reduced ejection fraction. The next highest risk, it's about 4%, is microalbuminuria and HFpEF. So if you're not checking microalbuminuria, you're missing an opportunity to detect a form of heart failure or to treat it. And this is the same thing with CKD. So this is GFR and that's albuminuria. So you got to do both. Please check the microalbumin. It's very, very powerful. So this is the SGLT2 inhibitors. This is from the original diabetes study. So we're going to keep going back and forth because the data is very useful. But you'll see here that overall, when the the GFR was less than 60, between 60 and 90, or even more than 90, there is a very powerful improvement of the renal outcome. So renal worsening, dialysis, or renal death composite in diabetes patients. So you can't ignore it even if the kidney function is normal. You can't. It's a very potent therapy in diabetic patients. Now, it was very nicely summarized all of the new evidence. So this is here in one slide, the positive cardiorenal intervention. So with finerenone, this is diabetes and microalbuminuric diabetic kidney disease, 22% cardiovascular benefit. In the fine arts heart failure study, 16% heart failure benefit. Semaglutide, flow, diabetes and CKD, 30% cardiovascular benefit. And in the SGLT2 inhibitors, both diabetes and non-diabetes, DAPA-CKD, 30% cardiovascular benefit, EMPA-KIDNey, 28% benefit. I'm not even talking about the kidney here. This is the survival cardiac benefit with these agents that I think means we got to do something and add them. So this is really this whole integration, right? Kidney function, complications of diabetes, cardiovascular disease, superimpose obesity on top of that, and you see you've got to do all of this. The reason why this is a multi-system disorder that's attacking all of this at the same time. So, you showed this very nicely. I'm just showing this for emphasis. We know in heart failure, and all the cardiologists know, there's a similar parallel when we took the heart failure and reduced ejection fraction. Adding a beta blocker to an MRA, to Entresto, to SGLT2 inhibitor does the same thing in terms of cumulative survival. This is all-cause mortality if you looked at the data from FLOW, SELECT, FIDELITY, and the SGLT2 inhibitor class, right? Compared to CANVAS, which is SGLT2 alone. So this is all-cause mortality. Look at that. If you take all three of these special new medications, you got 67%, 33% benefit. This is the kidney on the left, so that's the renal survival. It's big, but look at the cardiovascular survival and the overall survival. So you're adding about 3 years to each patient, and 3 years without dialysis. By doing what? More work, right? GLP-1, SGLT2, non-steroidal MRA. Very specific, but very, very valuable. So this is really a tremendous way of looking at this. So this is my sort of cardiorenal metabolic cheat sheet. I don't like the word cardio-kidney. I don't know. Does anyone agree with me? I think renal is better. It just flows more. I don't like it. But Anyhow, I think it gets the idea across. So it's simultaneous multiple risk factor control. It's worth it for survival, it's worth it for heart failure, it's worth it for the kidney. So you've got your DASH diet and 30 to 40 minutes of exercise. Not going to forget that, right? Referral to the lifestyle interventionist, diet, and cardiovascular rehab. Now, residual risk will still be there, right? So you've seen this table in multiple different forms. Aggressive LDL lowering, so Fourier, Aspire, so this is adding PCSK9. Lowering inflammation, so if you had a recent acute MI, maybe adding colchicine would be reasonable, right? Increased thrombotic risk, should you give them dual antiplatelet extended or add an antithrombotic like rivaroxaban low dose plus aspirin? Triglycerides, we haven't talked about that, but the REDUCE-IT study remains a very powerful study giving evidence of triglyceride lowering, right? So hypertension, we have a lot of hypertension data that's based on ACEs and ARBs. And of course, you have the diabetes risk, which comes from all of the data with SGLT2 and GLP-1. But what's new now, we've sort of added this ad hoc, these two extra columns. You now have obesity and you have CKD in addition. Two extra columns to deal with. And the treatments are right there. So you're going to look at the BMI, CRP, and waist circumference in the obesity patient. These is the biomarker. And you're also going to look at the UACR and the GFR as a specific renal risk that leads to cardiovascular events. And what are you going to do about it? Again, it's right there. GLP-1, SGLT2 inhibitor, and a specific non-steroidal MRA. So there's a lot of work to be done here. There's 6 different things on this table that we should give these patients, because everything on this table is evidence-based. Everything here reduces outcome or improves outcome. So, making it a little bit simple, this is actually a snapshot from our cardiometabolic guideline. We take every single one of these phenotypes and we try to add the level 1 medications. So your obese patient with diabetes, SGLT2 inhibitor, GLP-1, ACE inhibitor, lipid-lowering therapy, right? If they have renal disease, SGLT2, GLP-1, ACE inhibitor, ARB, finerenone, plus high-intensity lipid-lowering therapy, because if you have kidney disease, you are target organ damage, very high risk. Target LDL is 1.4, right? So they're all linked. So I think these are sort of just clues for these kind of patients. So the evidence-based gaps that he doesn't have. So he's only on perindopril and aspirin and high-intensity statin. So he needs to have an SGLT2 inhibitor. Why? Renal risk and risk of heart failure hospitalization, right? Regardless of his diabetes or pre-diabetes status. He has albuminuria, he has a reduced GFR, he has LV dysfunction. Everybody agree? Yes? Okay. How about finerenone to reduce renal risk and heart failure risk? So does he fall into the fidelity study? He's not really diabetic. He's not a fidelity patient, right? But he's a fine arts patient, isn't he? Right? He falls into the heart failure study, and therefore you're going to have an impact on helping his heart failure risk. You could say that you could put him on also another mineralocorticoid antagonist like spironolactone or eplerenone, but this is updated information. Now, we want his LDL to be less than 1.0. Right? This is the highest level of risk possible. He's had 2 events within 1 year. So we're not going to just say add ezetimibe, follow in 3 months. We're going to add the PCSK9 and ezetimibe and statin and then reassess in 4 weeks and see what happens. Right? This is the specific targeting you have to do. The other thing now is that it's fairly clear that you want to prescribe a GLP-1 receptor agonist, and the one with data in this patient, this is a select study patient, to reduce MACE, ASCVD events, and reduce weight and BMI. Now you could ask, is this a patient who falls into the STEP-HF study? No. He has LV dysfunction due to ischemia, and he doesn't follow the strict criteria that was used to enroll patients with STEP-HF. Remember, those patients had to have increased LV mass, dilated left atrium, normal ejection fraction, reduced E to E prime. A lot of diastolic parameters had to be abnormal for them to fulfill the enrollment criteria. But he has a very simple one. He has reduced ejection fraction already. Now target the blood pressure, but because of the heart failure, I would put this patient on sacubitril valsartan. So this patient was studied in the Paragon study, and we had a continuous ejection fraction from 40% all the way to 67%. The patients who didn't benefit were who? Males with an ejection fraction above 67%. So he's not in that range. So as soon as there's LV dysfunction, I think adding the sacubitril valsartan would be appropriate. The European guidelines differ. This is a concept from the American guideline and the label, but the European guidelines don't agree with this. And finally, we talked about this. Icosapent ethyl, omega-3, high dose, would be very appropriate because he has residual risk in the form of non-HDLC and high triglycerides. How many weeks did it take us to do this? This was a real thing. So we used to see this patient basically after his first discharge, every 2 weeks, like a heart failure clinic, and then every 4 weeks, and then every 6 weeks after that. So it took us about 8 visits to get him on all of this stuff. There's a lot of resources behind this, and of course there's also cardiac rehab going on at the same time. So you also think about the higher cost medications that need approval in these patients. Written approval, send us the A1C, no, he doesn't have diabetes, no, we're not going to pay for it, right? He's not diabetic. They don't cover GLP-1 receptor agonists. So that's another discussion. So anyway, it is certainly something you're going to have to conceptualize and use a lot of your time and effort to do. And sometimes having a specialized pharmacist, so Bassam Atallah is our specialized pharmacist, and he's part of the cardiometabolic group. When I was working in Cleveland, that was very helpful. So we actually had a tailored template that would help us guide through all of these points. Right, thank you.